Good morning, good day. I'm Silvana Luciani from the Non-Communicable Disease Program at the Pan American Health Organization in Washington, D.C., and it's with great excitement and enthusiasm that I welcome you all to this regional launch of the Global Cervical Cancer Elimination Strategy. I've been working for many, many years to improve public health programs for cervical cancer, so I'm so thrilled to see this global momentum to really accelerate efforts around eliminating this devastating disease that affects thousands of women worldwide. To commemorate this momentous occasion, we have several representatives from governments and civil society partners who will be speaking with us today about their unequivocal support to reach the global targets for cervical cancer elimination. And to help kick us off in our session today, Dr. Jarvis Barbosa, PAHO's Assistant Deputy Director, will provide welcome remarks in a pre-recorded message as he had a conflict in his agenda today. So let us welcome Dr. Barbosa in his message.
Good morning. My name is Jarbas Barbosa. I am the Assistant Director of the Pan American Health Organization. And I'm honored to join the WHO Director General, Dr. Tedros, in the call for global action to eliminate cervical cancer, a disease that affects thousands of our mothers, sisters, and daughters. This regional launch event is being held with representatives from ministries of health and civil society partners to demonstrate our full commitment and support to this ambitious endeavor to eliminate a highly preventable disease, cervical cancer. Cancer is the second leading cause of death in the Americas, and cervical cancer is among the leading types of cancer in women in our region. More than 83,000 women are diagnosed with cervical cancer, and more than 35,000 die each year from this disease. Like most diseases, cervical cancer exacerbates existing inequalities. This means women who are poor, who have limited access to health care services, and those living with HIV are particularly at risk of developing cervical cancer. Unlike other cancers, we have an effective vaccine to prevent cervical cancer. We also have tests to detect precancerous lesions and effective treatment to prevent these lesions from developing into cancer. That is why I am pleased to launch the strategy to eliminate cervical cancer in the Americas, which comes on the heels of the PAHO direct cancer adoption of the Regional Plan of Action for Cervical Cancer Prevention and Control in 2018. With this new elimination strategy, we are asking countries to reach 3 new targets for vaccination, screening, and treatment. First, we must ensure that at least 90% of girls under the age of 15 years receive the HPV vaccine that prevents cervical cancer. Second, we need at least 70% of women between the ages of 35 and 45 years to be tested for HPV and screened for cervical cancer. And finally, we must ensure that at least 90% of women diagnosed with cervical cancer receive prompt treatment, including palliative and supportive care when they need. While these targets are ambitious, especially in light of the new challenges posed by the COVID-19 pandemic, we remain optimistic that we can work together towards these targets. PAHO is committed to supporting our member states to reach these new targets, and we are counting on your full engagement. Today's generation of women can be the last generation to live with the threat of cervical cancer. I hope you join us in making this vision become a reality. By redoubling our efforts, we can eliminate cervical cancer once and for all. Thank you.
Great, thank you. And that was Dr. Jarbas Barbosa bringing us welcome remarks for this regional launch of the Global Cervical Cancer Elimination Initiative. And to bring the voices of women who've been affected by cervical cancer, we'd like to now show you a short video of women from the region.
El cáncer es una enfermedad que se lo come a uno en tan poco tiempo y en mi caso pues perdí una amiga por el cáncer y fue bien triste el verla a ella y ver el dolor que se sufre con ese tipo de enfermedades.
Luego entré con la doctora, luego la doctora me dijo que mi examen había salido positivo. Al principio dentro de mí sentí algo fuerte, pero como no soy de las personas que le gusta llorar y llorar y llorar, pues al mismo tiempo solo dije yo, Dios mío, en mis adentros lo dije, Dios mío, pues todo uno lo pone en las manos de Dios, primero que nada. Luego le dije a la doctora, dígame si me voy a morir o no me voy a morir. Entonces ella me dijo, todavía no se ha convertido en cáncer, me dijo, es algo que usted lo podemos, me dijo, como me dijo, que lo podíamos eliminar, o sea, lo podíamos tratar con el tratamiento se me olvida, sí, del BPH, pues entonces yo le dije, si usted está de acuerdo, pues me dieron que leyera el folleto para ver si yo estaba de acuerdo con el tratamiento. Entonces yo le dije a ella que sí, que estaba de acuerdo. Más que todo por mi vida, por la vida de mis hijas.
I do everything in my power to ensure that she has a bright future. I said yes to the HPV vaccine.
Todas las mujeres debemos de estar al pendiente de nuestra salud por el simple hecho de ser mujer, para vivir, para disfrutar a nuestros hijos, a nuestra familia y todo lo que se venga.
I'm very happy I took the vaccine, and I think all the girls out there should take it too to prevent cervical cancer. It's time to end cervical cancer.
That was excellent. And it certainly is time to end cervical cancer. So the threshold for cervical cancer elimination has been established as 4 cases per 100,000 women. And this may seem extremely ambitious, especially in our region where there are still many countries and pockets within countries where incidence rates are well over 20 per 100,000. But this elimination strategy with its 90, 70, 90 targets have been created based on data and evidence showing that it is feasible. And to present these data, I invite our next speaker, Dr. Jane Kim, who's professor of health decision science at Harvard University and who's part of the WHO consortia to model these data to present on the results. Over to you, Jane.
Thank you very much. Let me go ahead and share my slides. Did that work?
Yes.
Excellent. Okay, great. Well, thank you so much for the invitation to be here. I'm so pleased to present our work on estimating the global elimination of cervical cancer using mathematical models. I'd like to acknowledge that this has been a long and ongoing effort in collaboration with the World Health Organization and with modeling groups from different institutions, including the University of Laval in Quebec, Canada, and Cancer Council New South Wales in Sydney, Australia, along with my team at Harvard University. So there are several key questions to be addressed in order to make this call to action to eliminate cervical cancer a reality. The first is, what is the right cervical cancer threshold to achieve elimination as a public health problem? And you've already heard from Silvana that a threshold of 4 per 100,000 women for cases has been established, and I will be presenting our results in that context. The second question, what combination of screening and vaccination strategies can lead to elimination? When can elimination be reached for different strategies and in different countries? And what is the most efficient or cost-effective strategy to reach elimination? Can we reach elimination in a way that provides good value for money? Because of the limited time, I won't be able to spend too much time telling you about our methodology, but just to summarize the strategies and the approach, we used 3 independent mathematical models. This is to provide more reassurance in our results. So rather than relying on just a single model, we utilized 3 to project cervical cancer incidence and cases over time for 78 low and lower middle income countries under 3 main screening and/or vaccination scenarios. So scenario 1 involved high coverage of adolescent girls only vaccination. So 90% coverage of 9-year-old girls in a routine program, and a 1-year catch-up program of 10 to 14-year-old girls. And this scenario 1 assumes no change to the current screening coverage and practice. Scenario 2 involves the same high vaccination coverage, but in addition, we assume a one-time screening at age 35 years old, assuming that screening coverage can be ramped up over time and reach 90% screening coverage by year 2045. Scenario 3 involves, again, the same high vaccination coverage of girls only, and this time with 2 lifetime screens at ages 35 and 45 years old, also assuming that we can reach a high level of coverage of 90% by 2045. All of these scenarios assume that vaccination had 100% lifelong protection against 7 oncogenic HPV types that are included in the broad spectrum HPV vaccine. Screening was assumed to be HPV based and involved 100% treatment efficacy, and we assumed 10% loss to follow-up. So just to jump to our results, I'm going to show you how age standardized cancer incidence rates per 100,000 women, which is along the y-axis here, changes over the next 100 years along the x-axis for each of the models. And this is just to demonstrate our model consistency for the no further change scenario. We have the low income countries on the left and the lower middle income countries on the right. And you can see here that across the 3 different models that under a scenario of no further change, so this is no ramp up of vaccination or screening, that our models provided quite consistent baseline projections. And then in scenario 1, which again involves vaccination only, across the 3 models, we had also very consistent trends and results across the 3 models. So what we're going to show in the next graph is basically an average across the 3 models, just for simplicity. So now I'll show you the differential in cancer incidence across the 3 different scenarios. This blue line here is indicating our threshold of 4 per 100,000. And so in the low income countries, that has a relatively high starting burden of roughly 40 per 100,000 women, we see that cervical cancer incidence is unlikely to reach the elimination threshold when we only assume vaccination only. Okay, so this kind of stapled line here is representing our scenario 1, and we see that it never crosses the threshold of 4 per 100,000. However, with once in a lifetime screening, which is shown by this middle dotted line, we do see that we cross this 4 per 100,000 threshold at roughly year 2089. Okay, and then that occurs, actually, the crossing the threshold occurs 6 years earlier, when we assume that vaccination is offered alongside 2 times per lifetime screening. So that's the solid line here. In total, this translates to between 3.5 and 4.3 million cases averted compared to no prevention scale up. And this is, again, aggregated over the low income countries. And this is by year 2120, so within 100 years. On the right-hand side, for the lower middle income countries, we see that we have a starting prevalence that is far lower, almost half, roughly 20 per 100,000 women. And elimination is predicted to occur in all 3 scenarios and earlier. So in this case, with the vaccination and the 2 lifetime screens, we see it, the threshold crossing at around year 2069. And then in total, in aggregate, in the lower middle income countries, there are roughly 11.5 to 14.2 million cases that could be averted, depending on which scale-up strategy we're talking about. Now, another way to look at this is looking at country level results. And we can do this by referring to the world map, where we can see when and if different countries reach elimination over time for the different strategies. The dark blue region indicates a low burden, and this is at our threshold of 4 cases per 100,000 women. The lighter blue is indicating a slightly higher threshold that we had been also considering of 10 per 100,000 women. And then the red indicates a higher burden, greater than 10 per 100,000, with the darker shading indicating higher burden. So as the map changes over time, as I scroll through our slides, you can see that how these countries are changing with each of the strategies. You can also keep your eye on the left-hand side here and see how the proportion of countries eliminate by the different income groups and by region. Okay. So starting with our first scenario that includes vaccination only, this is the starting distribution, the current distribution of cervical cancer incidence in the 78 low and lower middle income countries. And over time, we don't see any changes. This is year 2030 now. We start seeing some changes in year 2045. In 2060, we start seeing some countries in Asia and Africa reaching 10 per 100,000. By 2075, more countries in Africa and the countries in the PAHO region are below 10 per 100,000. And then we see this trend continuing through 2120. And as you can see, there are several countries, even over 100 years that don't meet the elimination threshold of 4 per 100,000 with only vaccination. In terms of timeline, in regions that did achieve elimination, we see that occurring around year 2080 as the earliest, and then 2063 if we're adopting the 10 per 100,000 threshold. So now for scenario 2, again, this is the current year 2020 current cervical cancer incidence in the 78 countries. When we add to vaccination the once in a lifetime cervical cancer screening, we're going to start seeing countries crossing into the blue zone a little bit earlier. So here's 2045. In 2060, we see PAHO countries starting to fall under the 10 per 100,000 threshold. Here's 2075, 2080, 90, 2015, and 2120. So again, in 100 years. By the end of the century, we have most of the countries reaching elimination. We see that occurring between years 2072 to 2080, and earlier with the 10 per 100,000 threshold. But there are some countries in Africa and sub-Saharan Africa where we are not reaching the 4 per 100,000 threshold. So now for scenario 3, this is again vaccination and then assuming 2 lifetime screens. Again, not much happening even as early as 2030. Some countries are falling below the 10 per 100,000 in 2045. Here's what we look like in 2060. And then most countries are in the blue zone by 2075. So under 10 per 100,000. Here we're looking at 2080, 2090. And then by, again, the end of the century, we see most countries have reached the 4 per 100,000 threshold. And then this is occurring kind of between years 2067 and 2113 at the 4 per 100,000 threshold, and then as early as 2051 at the 10 per 100,000 threshold. Now, what I've showed you so far has been focused on the low and lower middle income countries. We also did an analysis. This is just going to be showing results from one model where we looked at elimination, the potential for elimination in the United States. We know that there has been relatively high coverage of screening, also reasonable coverage of vaccination. And so we wanted to juxtapose the findings from a high income country to those of what you just saw. So I'm going to just orient you to this graph. This is dotted line is showing you the 4 per 100,000 threshold. We also in the United States had considered a lower threshold of 1 per 100,000. This first black line represents our status quo, screening and vaccination. So this is without doing anything, without scaling up either vaccination or screening. And we see that even with the status quo, we do reach elimination of 4 per 100,000 by year 2038, okay? What happens if we add vaccination scale up? Well, this orange line represents the scenario where vaccination is scaled to 90% coverage. This is for girls only. And we see that the added benefit, right? The line does not change that much from the black status quo line. And that's because vaccination has already been in place in the US with reasonable coverage up to 60, 70% for girls. So increasing coverage to 90% actually doesn't provide us much more benefit in the context of existing herd immunity. Now, this green line represents screening scale up to 90%. And this is assuming 3 yearly cytology-based screening, which has been standard of care in the United States. And here we see that elimination at 4 per 100,000 occurs much earlier in year 2030. And this scenario even reaches down to the threshold of less than 1 per 100,000 in year 2064. In summary, what strategies lead to elimination when we're talking about a 4 per 100,000 threshold? In the low and lower middle income countries globally, 90% of girls only vaccination with 1-time or 2-time screening coverage is required to eliminate cervical cancer in many countries. In the PAHO region for the low and lower middle income countries, 90% of girls only vaccination and 1-time screening coverage is required. And then in a high income country such as the United States, elimination can be achieved by the status quo, but is expedited by increased screening coverage. And this is just to note that the 2030 WHO targets of the 90% vaccine uptake, 70% screening coverage, and 90% treatment access are very much on this path to cervical cancer elimination. These were embedded in our analyses. When does elimination occur? Across all low middle income countries between years 2060 and 2090. The low and lower middle income countries in PAHO are occurring between 2075 and 2080. And in a high income country such as the US, as early as 2030 out to 2038. So with that, I will turn it back over to our next speaker.
Great. Thank you very much, Jane, for this excellent presentation showing that vaccination together with screening at least twice in a lifetime will reach us to elimination in the US, certainly by 2030, and in the other PAHO countries in the next 50 years, and worldwide at least in the next 100 years. So again, this elimination target is feasible, backed by the data. So thank you again, Jane. And we know that government health policies and services and programs are really at the core of cervical cancer elimination. And so to illustrate the government commitments in our region, we have a panel of representatives from selected countries that will provide us with their commentaries. And I'd first like to invite our colleagues from Brazil, Dr. Antonio Braga, who's the Director in Primary Care of the Ministry of Health, together with Dr. Ana Cristina Pino, who's the Director of the Brazil National Cancer Institute, to provide their remarks. Over to you.
Braga, I guess you're the first one. Braga? Hello?
You must have gone. Adelante, Ana Cristina, por favor.
Él está on mute.
Ativa o microfone. It's because he
Olá.
Small introduction. Yeah.
Vocês me ouvem?
Sim, adelante.
Olá, me desculpem, meu nome é Antônio Braga, eu sou diretor do Departamento de Ações Programáticas e Estratégicas do Ministério da Saúde do Brasil. É com muita honra que nesse ato represento o ministro da Saúde, Eduardo Pazuello, do governo Jair Bolsonaro, Pátria Amada Brasil. Dizer para vocês que minhas palavras iniciais é para salientar que o governo brasileiro irá dar as mãos à Organização Mundial da Saúde para participar da erradicação do câncer de colo de útero. Eu sou médico ginecologista e obstetra e entendo que esse câncer é uma grande chaga social que acomete, em especial, as mulheres mais vulneráveis do nosso país. Para nós do governo, é incompreensível termos taxas de mortalidade por câncer de colo de útero que, a despeito de nas capitais ter apresentado uma queda, em termos de Brasil, ela se mantém estável nos últimos 30 anos. Num país que tem a vacinação contra o HPV pública, gratuita, mas que ainda não consegue atingir as suas meninas, e que tem dificuldade de fazer o seu rastreio num país de dimensão continental como o Brasil. Dizer que estaremos ao lado das instituições brasileiras, em especial do nosso Instituto Nacional do Câncer, com a doutora Ana Cristina, que falará em seguida, para pensarmos como fazer para aplicar as estratégias da Organização Mundial da Saúde para ajudar a erradicar esse problema das mulheres brasileiras. Por fim, dizer que não me preocupa que isso possa demorar um tempo, porque quem pensa em colher tâmaras jamais plantará tamareiras, porque as tamareiras demoram cerca de 80 anos para dar os seus frutos. O melhor presente que nós podemos dar para o futuro são as estratégias de agora eliminar o câncer de colo de útero e que as gerações futuras venham a se beneficiar dessas ações que o governo brasileiro publicamente assume o compromisso junto à Organização Mundial da Saúde e à OPAS de erradicar o câncer de colo de útero nas mulheres brasileiras. Muito obrigado, agradeço em nome do ministro Eduardo Pazuello e do presidente da República, Jair Bolsonaro.
So, okay, I'll list our main achievements and challenges according to each goal of WHO. So, concerning goal number 1, the coverage of HPV vaccination, main achievements were the introduction, as Braga mentioned, of HPV vaccine, the quadrivalent, at the National Public Health System in Brazil called SUS in 2014 for girls and boys. And another one is the implementation of the individual vaccination registry, which is called CIS-PNI, for the monitoring of doses given and girls assisted. So main challenges are still vaccination scale up, our current annual coverage according to 2019 data is 73.1% first dose and 47.4% second dose. Another challenge is the inclusion of schools as vaccination sites following international recommendations for teenagers vaccination. Go to the coverage with HPV DNA testing in women aged 35 to 45 years. So in Brazil, the Ministry of Health's recommendation is pap smear-based screening. So in this regard, our main achievements were sampling at primary care level all over the country, the evidence-based and updated guidelines on screening, improvements in the information system called CISCAM that monitors exams and women as a follow-up, and the implementation of a quality program for cytopathology labs at the National Health System in 2013, which is called Qualicito. Challenges are still the high percentage, around 9.7% of women 35 to 45 years never tested. And in the North region, which is the worst scenario in Brazil, it gets up to 12.8% of women never tested. Regional inequities, of course, like socioeconomical and and also accessibility. Expansion of this system called CISCAN to the whole country, but we still need to make improvements in the web service, which is necessary. Implementation of organized population-based screening, and most importantly, cost-effective evaluation of HPV DNA testing as standard for screening. Currently, Brazil is a participating center at a project called Marco Project in cooperation with NCI, Trimble knows that very well, and Fiocruz, that aims to compare effectiveness, efficiency, and economical feasibility of new screening strategies. And last but not least, the third goal, which is treatment coverage, including palliative care. Main achievements were guidelines for see and treat approaches using a native visual inspection and excision of the cervical transformation zone, monitoring of the time frame between diagnosis and first treatment by a tool called Panel, Oncology Panel, Painel Oncologia, of all cancers diagnosed and treated at the public national health system, which is available since 2018. And the reduction in mortality in all state capitals, as Braga mentioned, along the last decades. But many are the challenges still, like structuring of services for the diagnosis and immediate treatment of precancer lesions, like colposcopy, biopsy, and excision. Expansion of treatment offered, especially surgery and radiation therapy, and through a great national plan called the expansion plan in radiation therapy, which will deliver 100 solutions, radiotherapy solutions all over the country, and the reduction of the time frame between diagnosis and the first treatment. So 23% of cases are still above 60 days. So this is a real challenge for us. So thank you.
Thank you very much, Dr. Pino and Dr. Braga, for commenting on the efforts being made in Brazil to expand access and coverage for vaccination screening and treatment. Thank you. Now over to Costa Rica, and I invite Dr. Roberto Arroba, who's the head of the National Immunization Program in Costa Rica.
Hola, buenos días, doctora Luciani. Muchas gracias por la invitación a este lanzamiento regional para la eliminación del cáncer cervicouterino en la región de las Américas. Nosotros en el país somos realmente optimistas de lograr esta meta regional de eliminación de cáncer cervicouterino. Tenemos un excelente programa de inmunización. Es un programa que es universal. Tanto la parte pública como privada tienen acceso a las vacunas. Y además de eso, nosotros tenemos muy buenas coberturas de vacunación. Justo el año pasado iniciamos la vacunación universal contra papiloma. siendo que obtuvimos un 98% de cobertura con la primera dosis y un 95% en la segunda dosis. Por lo tanto, somos muy optimistas de seguir con estas coberturas en los años próximos. Somos claros y sabemos que es un reto muy, muy grande seguir manteniendo estas coberturas tan altas de vacunación. Pero bueno, tenemos una cultura de vacunación en el país, la gente es pro vacuna y además de eso tenemos leyes que nos ayudan en el caso de que un padre no quiera que vacunen a su hija. Nosotros podemos, mediante las leyes, hacer que vacunen a las niñas, porque es un derecho que tienen para justamente prevenir, evitar un cáncer que tiene una alta incidencia en nuestros países. El tema del tamizaje también es muy importante acá. Tenemos la seguridad social que prácticamente da para el 95% de la población y tenemos altas coberturas de tamizaje por Papa Nicolau. Y finalmente, quisiera mencionar que acá en el país tenemos experiencias muy importantes en el tema de investigación con la vacuna contra papiloma. Si recuerdan bien, el proyecto Guanacaste fue la punta de lanza para la vacuna contra papiloma y en este año también se está llevando a cabo otros estudios con el fin de poder tener un sueño, y es que en lugar de 3 dosis, como había sido inicialmente, se pasó a 2 dosis y que ahora sea una única dosis para el esquema de vacunación de los países, y esto nos permitiría además tener vacuna para niños y niñas. Por lo tanto, somos muy optimistas y pensamos que sí, es un reto grande para los países, pero además de esto, somos optimistas en que vamos a lograr la eliminación del cáncer cervicouterino. Muchas gracias.
Thank you very much, Dr. Aroba, for sharing your optimism about cervical cancer elimination in Costa Rica, and congratulations on those high vaccination coverage rates. So we're going to move over to the Caribbean now and to Suriname, and I invite my colleague, Dr. Elsdams from the Ministry of Health, medical oncologist, to provide her perspectives.
Thank you, Silvana, and thank you very much for the invitation to speak here today. So in Suriname, there are many, many problems and challenges. Of course, a high incidence rate, still 22 per 100,000 females. The high mortality rate pointing to still a high fatality rate, which of course is a similar situation in many countries in the region. And there's no decline in the last 30 years. This is really, I think, very embarrassing for my country. And this has everything to do with the late presentation because of the absence of a national screening program. And the other problem is we have no cancer registry, so we have no reliable data. We do have, I'm starting with telling the positive things, we do have a HPV vaccination. I'm very glad with that. But the problem is there's no monitoring and evaluation programs. So actually, we have no reliable data on the coverage. And we think it may be 50 or lower percentage. Treatment was improved. We had radiotherapy since 2012. I think this was really a major step forward for the treatment of cervical cancer in my country. But we still have dropouts, more than 10%. And this has much to do with fear and I think lack of support. So those are the challenges and the problems, just to name a few of them. So I'm going over to the opportunities. I think there are very important good things happening in my country. One of the most important things is the governmental commitment. This did not translate yet in a nice budget, I must admit that, but they did adapt the National Cancer Control Program for the coming 10 years, which of course includes cervical cancer elimination. And they already did, this is a new government this year, and they did include cervical cancer screening program for the coming year in their policy program. And of course, there's still the school-based HPV vaccination, and they still pay for it. So those are very important things, I think. The other good thing is we have a very committed oncology workforce. All cervical cancer cases are being discussed in a multidisciplinary team setting, and there's a dedicated treatment center, and this really improved treatment and decrease the waiting times. I just was hearing Dr. Aroba talking about. So in addition to that, this oncology workforce is busy with setting up a hospital-based registry as a first step towards a population-based registry. Third, but certainly not in the least, there's an increase in the community engagement. I think this is very important. We just had 2 projects that were very successful. One was a pilot rollout program, screening program, relating to the very many different ethnic groups in my country. And what they did, they used a community-based approach. They tailored it to the local situation, and they included a survey on barriers. And this gave us a lot of information on how to develop and implement a successful national screening program. And the other thing that was very successful was being done in the interior among the indigenous and the Maroon people. It was a project on increasing knowledge and awareness, and it immediately increased coverage in screening. So I think taken together in my country, there are many problems and we don't have a structure yet, but I think we do have the necessary building blocks to get a structural cervical cancer elimination program. And also, I must say thanks to the support of PAO. Thank you.
Thank you very much, Dr. Dams, and it's encouraging to see these important progresses being made in Suriname to have a structured program for cervical cancer. And thank you for highlighting the importance of engaging with women in communities and raising awareness and understanding the barriers. So over to the USA now, and I'd like to invite Dr. Ted Trimble, who's a researcher at the US Cancer Institute, which also serves as the WHO Collaborating Center for Cancer. Over to you, Dr.
Thank you, Silvana. We're excited by the opportunity of this global initiative because many of the interventions are based on research that we help support, whether it's through HPV vaccines or HPV diagnostics and triage, self-collection, new treatment algorithms are based on research that we helped to build. Just as an example, we are also working with the Gates Foundation in a study in partnership with investigators in Costa Rica comparing 1 versus 2 doses of HPV vaccines. We've also set up a new network involving sites in the Caribbean and Latin America to look at the intersection of HIV infection and HPV infection. My own institute, the National Cancer Institute, our sister institutes, the Centers for Disease Control and Prevention, are available to help with other PAHO member states in terms of technical assistance for cervical cancer prevention and control. We are also want to highlight some of the modeling that Jane Kim and her colleagues did looking at cancer treatment. I know Jane didn't have time to present it today, but there's good evidence that if we can improve access to treatment and improve quality of treatment, we can reduce the mortality of from cervical cancer by 2030, consistent with the goals of reducing NCD mortality of 30% by 2030. I also want to emphasize the importance of making sure that we have effective symptom management, survivorship, palliative care, all of which are interventions we know how to deliver, and we need to make sure that they happen routinely. Finally, I want to say we're looking forward to working with Silvana and her colleagues at PAHO to strengthen collaborations between PAHO member states, with WHO, with the International Atomic Energy Agency, IARC, and other UN agencies. Thank you.
Thank you very much, Dr. Trimble, and thank you for your ongoing support to this regional elimination initiative. And we know that eliminating cervical cancer will really require a multidisciplinary and multi-stakeholder effort. So to illustrate the breadth and depth of commitment that we have in the Americas regional civil society groups, we have an outstanding group of speakers in our next panel who will provide some remarks. And we'll start first with the Brazil Society of Immunization, and I invite Dr. Renato Kafuri.
Olá, Silvana, prazer estar aqui com todos, uma honra discutir um tema tão importante, numa meta que creio bastante ousada de atingirmos 90% de cobertura vacinal, 70% de cobertura de testagem e 90% de cobertura de tratamento para o HPV. Mas eu acredito que somente ousando com metas bastante específicas como essa, conseguiremos traçar objetivos como esses da eliminação do câncer cervical. Nos 3 pilares, prevenção primária, através de vacina, diagnóstico e tratamento, eu creio que a prevenção primária assume um papel importantíssimo, pois pode reduzir de maneira significante os desfechos de tratamento e de prevenção, como foi mostrado aqui. Agora, os desafios da vacinação do adolescente são enormes. Nós enfrentamos algumas enormes dificuldades em conduzir o adolescente às salas de vacinação, não só no Brasil, mas em todo o mundo. Eu acredito que inserir o programa de vacinação dentre outros programas de saúde do adolescente, como prevenção de drogas, gravidez na adolescência, educação, pode ser um caminho, bem como a vacinação de base escolar. Eu não conheço nenhum país do mundo que teve sucesso de coberturas vacinais que não fosse com vacinação em base escolar. Então, acho que essa parceria e aproximação dos ministérios da educação e da saúde são cruciais para o sucesso de qualquer programa de prevenção, senão dificilmente nós vamos avançar na vacinação dos adolescentes se não tivermos esses programas de base escolar. Aqui no Brasil, a Sociedade Brasileira de Imunizações, que eu represento aqui, em parceria com outras entidades, como a Sociedade Brasileira de Pediatria, como o Unicef e a própria Organização Pan-Americana da Saúde, tem auxiliado o Ministério ao atingir coberturas vacinais, aumentando a informação para a população. Muitas vezes, por questões de compliance, por questões, às vezes, administrativas, o poder público tem dificuldade em acessar, de realizar campanhas, conseguir apoios, verbas, patrocínios para a realização disso. Eu acredito que as sociedades científicas, cumprindo seu papel de informação, não somente do profissional da saúde, mas também da informação da população, pode sim ser um catalisador dessas relações, estabelecendo um eixo de ligação entre a comunidade, entre o poder público, facilitando com que essas informações, facilitando com que a divulgação do conhecimento, especialmente neste momento de mídias digitais, nesse momento de tantas fake news, nós consigamos ter um êxito maior. A comunicação é fator indispensável para que nós consigamos atingir esses objetivos. E nós só vamos conseguir comunicar as nossas intenções, os nossos esforços e o valor das vacinas se nós fizermos isso de uma maneira que atinja os nossos adolescentes. A comunicação é tudo. Muito obrigado aí pela oportunidade de estar com vocês e sempre disposto a colaborar pessoalmente em nome da Sociedade Brasileira de Imunizações.
Excellent. Thank you, Dr. Kafuri, for your continuing support and for highlighting the importance of working with education for school-based HPV vaccination. We turn now to Basic Health International, an NGO and official relations with PAHO, and to Dr. Mauricio Massa for some words.
Muchas gracias, Silvana, por darnos la oportunidad. Hoy es un gran día. Eliminar el cáncer de cuello uterino sabemos que está en nuestro alcance. Tenemos las herramientas, vacunas, pruebas de... Ante la adversidad siempre hay que ver la oportunidad, y la pandemia de COVID-19 ha hecho que todos los países, no solo en la región, sino que a nivel mundial, aumente su capacidad de laboratorio para pruebas biomoleculares. Como parte de la estrategia para eliminar este cáncer, llegar a pruebas de alto rendimiento, es donde esto toma mucha importancia, ya que las pruebas biomoleculares para detectar el virus del papiloma humano toman un papel, deben de iniciar esta transición. Es complicado, pero nuevamente esta es una oportunidad para mejorar nuestros programas de tamizaje, desde los sistemas de vigilancia para el tamizaje hasta tener control de las mujeres que son tamizadas y tratadas en todo su manejo. Es extremadamente importante. Dentro de varios documentos que se están publicando alrededor de esta iniciativa, el día de hoy, y ampliación de pruebas para el virus del papiloma humano como parte de un programa programa integral de prevención y control de cáncer de cuello uterino. Es una guía paso a paso iniciar el proceso de introducir pruebas biomoleculares. Los países de la región tienen proyectos desde pilotos hasta unos que ya han incluido la prueba del virus del papiloma dentro de su presupuesto nacional. Tenemos las herramientas, es el momento de actuar. En El Salvador se ha iniciado con la vacunación, pruebas de VPH y tratamiento.
Dr. Mazza, we've lost the connection. I know that you're based in El Salvador and there were some problems with weather, and so the internet has been affected.
Planificación, pero es algo que es posible y está en nuestras manos. Esperamos que todos los países de la región para poder llegar a estas metas.
Great, thank you. Thank you very much, Dr. Mazza, for your highlighting the importance of HPV testing and the new tools that are available to help guide countries to introduce HPV testing as part of cervical cancer screening. We turn now to the Healthy Caribbean Coalition, another NGO that's in official relations with PAHO, and over to Heather Mia Usher, based in Belize, for some remarks.
Thank you, Savannah, for the invitation. The Healthy Caribbean Coalition applauds the WHO on the launch of this historical global strategy, which is specifically geared towards the ambitious but achievable goals of eliminating cervical cancer. This is a collective goal that together we'll be able to achieve in the Caribbean region, with the support of our partners like PAHO, WHO, CARFA, and regional member cancer societies of the HCC. The HCC and the Belize Cancer Society continues to partner as we have recognized cervical cancer in the region as an immediate threat to the health and the livelihood of our nations, especially our girls and our women. The HCC has successfully partnered with various international organizations and national cancer societies to advance cervical cancer prevention in the Caribbean through advocacy and action aimed at building the capacity of civil society to educate, to vaccinate, to screen, to diagnose, and to treat our Caribbean girls and women. Since 2013, the HCC and the Australian Direct Aid Program has supported my organization, the Belize Cancer Society, and the Belize Ministry of Health and the Ministry of Education in the delivery of education and screening for thousands of Indigenous and indigent Belizean women in my country. We've used multi-ethnicity approaches as well as for the joint introduction of our national HPV vaccination program. And we included associated education campaign to support our teachers, faith-based organizations, and to gain parents' approval for this vaccination program. Notwithstanding all the efforts that we have to put into resource mobilization, the work of the HCC has been recognized globally by the WHO Global Coordinating Mechanism on NCDs in 2015 and by the NCD Alliance in 2017, when the HCC received the Chargé Civil Society Award of Excellence in Access to Care. Today, the HCC released an open letter to our heads of CARICOM, calling on them to prioritize cervical cancer elimination in their national health responses and re-emphasizing the HCC's commitment to support this agenda. We have long believed that the goal of eradicating cervical cancer, although no small feat, especially in resource-limited settings such as ours in the Caribbean, was achievable. With the launch of this global strategy, our goal is within reach now. There is now a strategy to drive multi-sectoral and stakeholder approaches, member state-led actions towards the attainment of this 90-70-90 target. We take this opportunity to thank the WHO and PAHO for all they have done. And we continue to call on our Caribbean governments and regional institutions such as CARFA and CARICOM, with the support of the WHO and PAHO, to continue to invest in civil society partnerships and increase and intensify our collective efforts so that together we may reach these ambitious targets and ensure that no Caribbean woman dies unnecessarily of this preventable disease. We once again applaud the WHO and we thank you for this opportunity.
Thank you very much, Heather, for reminding us of the importance of civil society partnerships with governments. And now we're going to move to the Professional Association, the International Federation of Cervical Pathology and Colposcopy, to Dr. Carlos Perez. Dr. Perez.
Muy buenos días para todos. Nuestra federación nace en diciembre de 1972 en Mar del Plata. Cumplimos 48 años. Los objetivos fundacionales de nuestra federación fue estimular la investigación básica y aplicada y la difusión del conocimiento en patología cervical y colposcopia, estimular la creación de sociedades nacionales, contribuir a la estandarización de la terminología y a la evaluación de los procedimientos diagnósticos y terapéuticos en patología cervical y la prevención primaria y secundaria del cáncer cervicouterino. Conocedores en la actualidad de grandes desarrollos como el de la vacuna que previene el cáncer cervical, pero por su baja cobertura es difícil pensar una reducción a corto plazo. Entendemos que la prevención secundaria también será la necesidad imperativa para la prevención del cáncer cervical. La Federación Internacional de Colposcopia, como una institución con vocación en la búsqueda de la excelencia de un grupo de sociedades internacionales, proveerá adecuadas respuestas a los grandes desafíos de nuestro tiempo. Nuestra contribución para unirnos a la campaña de eliminación del cáncer cervical está basada para los años venideros en, primero, difundir nuestro curso de educación a distancia, iniciado y liderado desde el año 2014 por el Dr. Wander Prendiville, traducido a 6 idiomas con alumnos en todo el mundo para la enseñanza y control de calidad de la colposcopia. La enseñanza y difusión en la prevención primaria y secundaria, no solo para especialistas en colposcopia, sino ginecólogos, médicos generales, estudiantes, enfermeras y personal para promoción y prevención en el mundo entero. Adicionalmente, la revisión de la nomenclatura de la IFCPC para la colposcopia, que ya cumple 10 años, la última fue en Río 2011, y para el Congreso del año entrante en la India en el año 2021, tendremos nuevamente una clasificación. Esta está liderada por el Dr. James Bentley y por el suscrito. Y para hacer toda esta unión con la estrategia de eliminación del cáncer cervical, contamos con un grupo muy comprometido de trabajo que en particular para este proyecto va a ser liderado por el suscrito y el Dr. Silvio Tati a través del Comité de Educación para el Proyecto de Eliminación del Cáncer Cervical. Estamos listos, comprometidos y seguros que nuestro trabajo aportará un grano de arena en esta titánica tarea de eliminar el cáncer cervical de la faz de la Tierra. Muchas gracias.
Excellent. Thank you very much, Dr. Perez. And we look forward to working together to build capacity for cervical pathology and colposcopy. Over now to the Medical Oncology Association of Latin America and the Caribbean and Dr. Eduardo Cazap.
Buenas tardes a todos. Muchas gracias, Silvana, por esta invitación. Todos reconocemos al cáncer como una enfermedad crónica, pero esa es en realidad una definición más bien de tipo de políticas públicas. 30% de los cánceres humanos son transmisibles y este es uno de los casos paradigmáticos, que es el cáncer de cuello uterino, donde hay una vacuna y ahora el problema para el mundo es cómo utilizarla mejor. Y creo que debemos seguir el concepto del control de cáncer, el concepto integral de control de cáncer, desde la educación, la investigación y la prevención primaria hasta la rehabilitación final de vida, acceso a la morfina y los curados. En ese sentido, nuestra organización está trabajando en esto en 4 estrategias combinadas. Una es la educativa y para la población general, por lo cual el proyecto del Código Latinoamericano contra el Cáncer, que va a emitir 12 recomendaciones totalmente demostradas para la prevención primaria y secundaria del cáncer, junto con IARC y la OPS y nuestra organización, es una de las estrategias. La otra de las estrategias es que no hay un accionar eficiente a través de los países, sino es a través de los planes nacionales de cáncer. Y esto está dentro del ICCP, que es, como ustedes saben, una coalición que promueve que todos los países del mundo tengan planes nacionales de cáncer y datos, registros, elemento básico para planear las estrategias. El otro proyecto creo que también va a conllevar a esto es un proyecto regional que llevamos con la Universidad de Harvard, el Instituto de las Américas de Miami y la Unión Internacional contra el Cáncer, que es la iniciativa integrada de control de cáncer en América Latina, que está produciendo documentos sobre cómo se mejoran los sistemas de salud en nuestra región y ya pueden ser, los pueden encontrar ustedes en la página web de la UICC en ICCI, en castellano y en inglés. Y la última avenida es la parte importantísima de la prevención primaria y secundaria. Y esto lo efectuamos a través de la iniciativa cervical de la coalición SLACOM con RING, la red de institutos latinoamericanos de cáncer, que ahora trabajamos en conjunto, y creemos que esta también es la cuarta herramienta para tratar de que la América Latina, en una forma coordinada y estratégica, avance en el control del cáncer de cervix. Muchas gracias a todos.
Thank you, Dr. Kazap, for the support, continuing support with RINC, LACOM, and all the partners that you bring with you to the region. And we look forward to continuing working together. Now we move to Dr. Mila Salcedo from the MD Anderson Cancer Center, who's also with the Santa Casa de Misericordia de Porto Alegre and Universidad Federal de Ciencias, for some words of support. Over to you, Mila.
Thank you so much, Silvana, for the invite and for the opportunity. Eu vou falar um pouco, então, sobre o MD Anderson Cancer Center, que é uma instituição colaboradora da OPAS, e o nosso comprometimento como instituição com a estratégia global da OMS para a eliminação do câncer de colo do útero. Nós fizemos contribuições excepcionais para melhorar a prevenção e o tratamento do câncer de colo do útero em todo o mundo, por meio de atividades interdisciplinares em pesquisa, educação, defesa do interesse dos pacientes e serviços clínicos. A nossa equipe construiu um programa contando com muitos colaboradores globalmente, e é um programa abrangente para aumentar a capacidade clínica, com orientação e treinamento de profissionais da saúde em regiões de poucos recursos e países de baixa e média renda. Foi desenvolvido para a região das Américas, mas é para o mundo todo. O MD Anderson vem desenvolvendo projetos de pesquisa relacionados ao câncer do colo do útero, com parceiros na América Latina, especialmente o Brasil e El Salvador, em parceria com a doutora Rebecca Richards-Gordon e sua equipe da Rice University. O desenvolvimento de novas tecnologias tem contribuído para a melhoria da prevenção do câncer de colo do útero, especialmente em áreas de recursos limitados. O MD Anderson, junto com instituições colaboradoras do Brasil, também está comprometido em eliminar o câncer de colo do útero na África, com foco principalmente em Moçambique. Como parte desse programa, nós oferecemos treinamento em colposcopia e LIP, além de realizar estudos, pesquisas para melhorar os serviços de prevenção, e uma equipe multidisciplinar ajuda a melhorar as habilidades e aumentar a capacidade dos médicos e enfermeiras locais. Os médicos do Brasil e do MD Anderson em conjunto atuam como mentores da International Gynecologic Cancer Society, IGCS, para treinar médicos em Moçambique, para diagnosticar e tratar doenças pré-invasoras e tratar mulheres com câncer ginecológico. Os primeiros 3 ginecologistas oncológicos em Moçambique acabam de se formar, e as mulheres moçambicanas com câncer de colo do útero passaram a ter acesso a cuidados com especialistas agora no país. A IGCS também apoia o programa de treinamento em oncologia ginecológica na América Latina. Para a sustentabilidade desses programas, nós usamos Project Echo, que são videoconferências regulares, baseadas em casos clínicos, para telementoria e apoio contínuo aos profissionais da saúde. Um dos nossos programas, com foco no tratamento do câncer ginecológico, conta com uma rede de mais de 14 países da América Latina. Esse ano, nós também iniciamos um programa que aborda a eliminação do câncer de colo do útero nas Américas, em colaboração com a OPAS e o Instituto Nacional do Câncer dos Estados Unidos. A nossa equipe do MD Anderson colabora com muitas instituições e sociedades para defender a prevenção e o tratamento do câncer do colo do útero. E nós temos muito orgulho de trabalhar com essa estreita colaboração com a OPAS e com os nossos parceiros. E estamos honrados em poder contribuir com essa iniciativa tão impactante, esse dia tão importante de hoje, né? E temos o potencial de estender esses programas para outros países e outras regiões. Muito obrigada.
Thank you so much, Dr. Salcedo, for all your commitment and support and partnership to build capacity for diagnosis and treatment of both pre-invasive and invasive cancer in our region and in the world. And we go now to Rotary. Many of you are familiar with Rotary as a community agency and leading the global polio elimination effort, and we're proud to have Rotary as a partner with us in this elimination effort for cervical cancer. Over to you, Carl Diekman.
Thank you, Silvana. And greetings from the Health Education and Wellness Rotary Action Group, often referred to as HURAG. I'm Carl Diekman, a member of the Rotary Club of Woodland, California, USA, and a director for HURAG, where I primarily focus my efforts on cervical cancer prevention. HURAG began to encourage Rotarian participation in cervical cancer prevention efforts after our participation at the Investing in Cervical Cancer Prevention 2015-20 conference in London on November 4th, 2015. Today, I am honored to represent the hundreds of Rotarians from around the world who are members of HURAG and focus their effort on cervical cancer prevention. I want to tell you briefly about the projects that Rotarians and their partners engage in. Rotary projects typically involve a host Rotary club in the country where the project occurs and a Rotary club or clubs from different countries or a different country. Projects range from $30,000 to hundreds of thousands of dollars, with most funding coming from Rotarians and the Rotary Foundation. Projects are always built around needs as established by the community where the project occurs and where commitments have been made to sustain the effort once the project partners have completed their work. We typically support training programs, equipment purchases, awareness campaigns, and much more. In recent years, Rotarians have established more than 40 projects that have focused on one or more aspect of cervical cancer prevention, treatment, or care for women who have cervical cancer. I'd like to mention two examples. In Ecuador, Rotarians from Alberta, Canada, and Ecuador are transferring knowledge by training local clinicians in VIA and cryotherapy in conjunction with a clinical project to serve women who otherwise could not receive examinations. In Nicaragua, Rotarians from California and Nicaragua provided a VIA and treatment training program that certified clinicians in VIA, cryotherapy, and LEAP at 5 clinics in Leon and the Bluefields region. After a year-long training program and hundreds of examinations, 5 clinics were outfitted with the necessary equipment to continue the work. Today, Rotarians are exploring opportunities to add new technologies as they continue to expand their projects. The adoption of the cervical cancer elimination strategy offers Rotarians a guide for future projects, and we are very grateful for the leadership of the Pan American Health Organization and the World Health Organization for adopting and promoting it. Thank you.
Thank you very much, Carl. And to all of our civil society partners, I'm really grateful for all the support we have. We have many, many more professional associations and NGO partners who didn't have time or space on our panel. So we've put together a little video of all the others and that we'll share at the end of this session. But right now I'd like to turn over to my colleague, Dr. Lucia de Oliveira, who is the Regional Advisor on New Vaccines and the Immunization Unit at PAHO, to provide some final concluding remarks. Over to you, Lucia.
Thank you, Silvana. I'm going to take advantage. I'm going to talk in my original language, Portuguese. It's not always that you have this opportunity. Muito obrigada, Silvana. É privilégio para a unidade de imunizações poder fazer o encerramento desta sessão, desse dia tão importante, celebrando a eliminação do câncer cervical. Creio que foi um estímulo para todos nós que trabalhamos com a eliminação do câncer cervical, escutar aos países, as propostas que os países estão tendo, como estão enfrentando os desafios, que são muitos e sabemos, e também da sociedade civil, que sabemos também que é muito importante que os ministérios de saúde estejam aliados à sociedade civil, para que cheguemos a essa meta que estamos querendo alcançar. Vou repetir, porque eu acho que é algo que tem que estar na nossa mente o tempo inteiro, 90% de cobertura vacinal, 70% de screening, de triagem, e 90% de tratamento. Esses números têm que estar na nossa mente todo o tempo, porque é com estes números que nós vamos alcançar esta meta tão importante em termos de saúde pública que todos estamos almejando. Queria também dizer que foi importante ver que tivemos mais de 400 participantes nessa sessão. Isso significa que são mais de 400 pessoas que estão interessadas, como nós, em chegar a essa meta. Muito obrigada e parabéns pela realização do evento.
Excellent. Thank you very much, Lucia, and thank you to all our speakers, our partners, our participants, and especially our interpreters to allow us to transmit this in 3 languages. And we look forward to working together towards cervical cancer elimination in the Americas. And we'll end now with the video of all the additional supporting organizations, institutions, and individuals who'll be working with us as we go forward. So over to the last video, and I Wish you all a great day after the video. Thank you.
Desde la Agencia Internacional para Investigación en Cáncer en Lyon, Francia, tuve el privilegio de dirigir una serie de estudios epidemiológicos en unos 40 países a través del mundo, incluyendo la mayoría de los países latinoamericanos. Estos estudios demostraron sin lugar a duda que el virus del papiloma humano es la causa principal y necesaria del cáncer del cuello uterino. Este descubrimiento hizo posible el desarrollo de dos armas ideales, una vacuna profiláctica que protege contra la infección por el virus y puede eliminar un 70 a 90% de los cánceres asociados por él, y una prueba o test de VPH que permite la detección de lesiones precancerosas del cáncer de cuello uterino con gran precisión. Lo trágico es que a pesar de que estas dos armas han estado disponibles durante más de 20 años, el cáncer de cuello uterino continúa siendo un problema grande de salud pública.
O Brasil é país continental e com diferentes realidades, o que reflete a diversidade de toda a América Latina. Infelizmente, a cobertura do rastreamento em nosso país é baixa. Aumentar a cobertura populacional da vacina contra o HPV é ainda um desafio. A pandemia da Covid-19 torna esse desafio ainda maior. Temos que mudar essa triste realidade. Temos um compromisso com todas as mulheres com câncer de colo uterino, oferecendo um tratamento multidisciplinar, oportuno e adequado, garantindo suporte integral a essas mulheres e seus familiares, em todas as etapas do tratamento e segmento. Esse é o nosso compromisso, não apenas dos profissionais de saúde, mas de toda a sociedade.
Las mujeres con VIH tenemos mayor riesgo de contraer cáncer cérvico-uterino. Somos una población en situación de mayor vulnerabilidad. Esto se debe al estigma y la discriminación, y también la violencia de género.
HPV vaccination, or the implementation of HPV vaccination, along with screening and treatment of pre-invasive and invasive lesions, may be the last meaningful intervention that will eliminate and eradicate cervical cancer. But we have to do this together as a whole of society effort in order to save our boys and girls once and for all.
El Instituto Nacional de Cancerología es asesor del Ministerio de Salud y Protección Social y de todos los actores del sistema. La ciudadanía tiene muchísima confianza en el instituto, por eso podemos apoyar para que las personas sientan que disponemos de una vacuna muy segura que debe ser aplicada a las niñas. Debemos promover la tamización y la detección temprana en las diferentes regiones de acuerdo con los recursos y queremos que la mayoría de las mujeres en el país tengan la certeza de que esta patología se puede eliminar.
Nosotros tenemos acá en el país una estrategia y es vacunar a las niñas en las escuelas. Esto nos ha permitido lograr altas coberturas de vacunación. Tal es el caso que nosotros iniciamos el año pasado la vacunación universal contra papiloma y logramos obtener coberturas del 98% en la primera dosis y del 95% en la segunda dosis. Esto para nosotros es muy importante porque nos asegura tener altas coberturas, población cubierta, y lo que queremos es que en unos 20 años, cuando estas niñas ya estén en edad adulta, pues estén protegidas y podamos prevenir y eliminar el cáncer de cervix.
Cervical cancer is preventable. We need to do it through vaccination, we need to do it through screening and early detection. These are things that are accessible and available all over the world, and if we work together as one, it's time to end cervical cancer once and for all.
Cervical cancer can be a curable cancer, yet millions of women around the world who contract cervical cancer are dying with pain because of no access to the appropriate treatment. But we know that with prevention, with screening, with access to treatment, these women can be cured and be back to their family, to their kids, to the society, and make a contribution to the world. Yes, it is time to end cervical cancer.
When we think about cervical cancer elimination, we need to think about it in a comprehensive way that includes early detection, vaccination, and also treatment. We need to continue to invest in radiotherapy on a global scale to treat this devastating disease and cure women so that they can return to their productive lives. It's time to end cervical cancer.
It is indeed astounding to be able to talk about meeting the 70-90 targets and saving lives of thousands of women worldwide.
Las mujeres relegamos a hacernos un PAP por las múltiples actividades de las que nos hacemos cargo. El trabajo, el cuidado de la casa, los niños, la familia, además de que un examen ginecológico no siempre es agradable. Pero ahora existe un nuevo método altamente efectivo, el test de BPH, que nos da a las mujeres la posibilidad de hacernos la toma nosotras mismas, en la casa, incluso en un centro de salud. Es un método revolucionario porque nos da autonomía a las mujeres en la prevención del cáncer cervicuterino y es un gesto simple con alto impacto en la vida de las mujeres.
I can contribute to the elimination of cervical cancer by increasing access to preventive measures like the HPV vaccine, screening and early detection services in my community. And I've been working hard to ensure access, but people still have significant barriers to care due to lack of health insurance, structural barriers, and intrinsic racism that's built into our healthcare system and institutions and in our communities. So we must fight to overcome these barriers and eliminate cervical cancer once and for all.
En la región centroamericana se ha realizado mucho en el tema de cáncer cervicuterino, desde los estudios de historia natural de la enfermedad que se realizaron en Guanacaste, Costa Rica, hasta Panamá, que fue uno de los primeros países del mundo en introducir la vacuna del virus del papiloma humano en su población. En El Salvador se introdujo pruebas biomoleculares de bajo costo para tener un programa de tamizar y tratar con crioterapia. En Guatemala se incluyó la autotoma dentro de sus guías para aumentar la cobertura de tamizaje. Y en Honduras se ha aprendido mucho de la termoablación como una alternativa para tratamiento. Estas son herramientas básicas que nosotros necesitamos para poder realizar la eliminación de esta enfermedad en nuestra región. Hay que unir esfuerzos, hay que unir conocimiento para hacer esto posible.
As providers, we need to ensure that every eligible patient receives vaccination against the virus that causes cervical cancer, HPV. We also have to assure that our patients get screened and treated for any precancerous lesions.
El desafío para poner en marcha esta estrategia de eliminación es ahora mucho más grande porque la pandemia para el COVID-19 ha puesto en peligro muchos de los programas de prevención. Ahora que el mundo entero espera ansiosamente una vacuna contra el COVID-19, debemos hacer todos los esfuerzos para utilizar la vacuna contra el VPH, que es una vacuna segura, eficaz y capaz de eliminar el cáncer de cuello uterino.
Juntos mudaremos a triste realidade do câncer de colo uterino em todo o mundo.
So once again, thank you everyone for joining us in this historic momentum to launch global elimination for cervical cancer. And that concludes our session. Thank you. Have a great day.